Welcome to a perspective roundtable of the New England Journal of Medicine. I'm Tom Lee, an associate editor of the Journal and network president of Partners Healthcare System here in Boston. I'll be the moderator today of this discussion of a topic that is on the minds of many of us in healthcare. What is the impact of the current economic downturn going to be for healthcare? And particularly, what is the impact on the prospects for healthcare reform in the United States? With me today, I've got three discussants with complementary and some overlapping expertise. On my right, I've got Dr. James Mongan, the CEO and president of Partners Healthcare System here in Boston. I've got Meredith Rosenthal, an economist who's an associate professor of health economics and policy at Harvard School of Public Health. And on my left, John Oberlander, a health policy expert and associate professor of social medicine and of health policy and management at the University of North Carolina. I think we should begin with that most basic question and turn to our economists and ask, how bad is it? Meredith?
Well, Tom, as you know, according to the experts at the National Bureau of Economic Research, we've been technically in recession for over a year now. And most recently, the unemployment news has been particularly bad. We're currently at an unemployment rate of 7.2%. Many experts believe we'll get at least to 9% by the end of the year. The increase in unemployment is directly linked to coverage because of the nature of our employer-sponsored insurance system. And so there will be increasing numbers who have lost employer-sponsored coverage, may not even be able to afford to pick up COBRA coverage. And at the same time, state budgets are also in crisis. There may be cutbacks in Medicaid, S-CHIP, other coverage programs that have typically picked up in some of those places where private insurance has dropped off. And so I think at the individual level, we may see fairly dramatic increases in loss of coverage.
So Jim, as the percentage of people who are uninsured or underinsured starts to pick up, what do you see happening for the hospitals?
Well, of course, it poses a real challenge for the healthcare system because recession or no recession, people continue to get sick, and therefore the demand, by and large, remains steady. There may be some decrease in demand for purely elective services, but by and large, steady demand, and yet the resources potentially available to the institutions, as I say, can be squeezed, particularly on the Medicare and Medicaid side. I would say this dilemma is particularly acute for public hospitals, which have a very high percentage of uninsured or underinsured patients and are more vulnerable to cuts in Medicare and Medicaid.
So John, you've been following carefully the efforts to push for universal access in Washington. What's your sense of the outlook now?
I think the window has opened higher than it had opened 6 months ago. There's going to be a tremendous increase in the number of uninsured. If the past is any indicator, I think for every 1 percentage point increase in unemployment, we gain another million without health insurance and another million enroll in Medicaid. That is going to create tremendous pressures to do something in health reform in coming months. So I think there is going to be this pressure for health reform. On the other hand, the question, and this is always the question in healthcare, is how do you pay for it? And we're going to be looking at a budget deficit next year that is over $1.5 trillion. And that's going to pose, I think, the hardest challenge for reformers.
Meredith, I know you work with a lot of payers and their clients and employers. What's your take on what they're thinking?
The last time we tried to move towards national health care coverage reform, the employers were very much in the opposition. I think today, in part because of the economy combined with the cost of employer-sponsored insurance, employers are actually much more willing to consider participating in a reform. And I think that is very important.
The problem is they're not united. You have many large employers who already provide health insurance and they have one set of interests. You have small employers who often do not provide health insurance and they think very differently about this question. On the one hand, employers don't like the current system. They complain a lot about how much they have to pay and so forth. On the other hand, they tend not to like the proposals that are there for reform. And so when you're talking about health reform coming up in the next Congress, and the most popular proposals all include an employer mandate, are they going to move from the point of being dissatisfied with the system to the point where they're willing to accept some form of employer mandate? I don't think we know yet.
There's a lot of talk these days about a healthcare Fed.
Well, certainly Secretary Daschle, who's going to head up Health and Human Services, has been the most prominent advocate recently of this idea. And what he wants to do is really create an institution that's insulated from politics. What he argues is that Congress hasn't done a very good job managing healthcare, and it shouldn't micromanage a lot of the healthcare decisions about benefit levels and what Medicare should cover and what new technologies should be adopted into a health insurance system. And so he wants to create a body that is insulated from politics and has the expertise to make those kind of decisions. Now, the question that you get in immediately with the Fed language, the other Fed has actually very few policy levers that it pulls, and right now it's pulling them and it's not doing too well. A healthcare Fed presumably would have a much more complicated story to deal with. Many different policy decisions. I think it would be a very difficult thing. I think substantively it's a good idea. How you get there politically, I don't know.
Meredith, do you have any take on the reaction of payers toward this kind of development?
Well, I think, as John mentioned earlier, I think the payers, whether we're talking about large purchasers, large employers, or health plans, I think the notion of greater regulation of any kind is not one that they tend to embrace. And I think this idea behind the Healthcare Fed and related policies, for example, the new Comparative Effectiveness Institute that some have proposed, these all really talk about centralizing decision-making in some way. I think any move in that direction is likely to make the payers fairly nervous.
I think it does grow out of some sense of frustration with the inability of our current highly politicized congressional system to make many of the kinds of decisions you have to make in the healthcare area. On the other hand, whether Congress is really going to be willing to abdicate that amount of responsibility to an independent agency, I think is a very important question. I might add on a somewhat wry note, I think one of the reasons why there's so much support among health policymakers for this idea is many of them see themselves as members of this health fed, so it has a certain appeal, if you will. You know, the rate regulation question is an interesting question. I think the nation has to make some fundamental judgments about the extent to which it really does want to limit expenditures for health care, and we're very ambivalent about that as a nation. If we decide we really do, then ultimately I think that does move you down a regulatory path. But three things that always have to be kept in mind about regulation. One, it's not a panacea. Secondly, it's technically very difficult to do. And thirdly, I would say any kind of price setting or rate setting methodology builds up a great deal of strain over time. It's not a magic answer. If the country really wants to act with great strength in the issue of healthcare costs, it's something that we may well have to consider.
Well, I have to say, listening to Jim speak, the first thing I was thinking about, of course, was the Resource-Based Relative Value Scale, RBRVS, the Medicare fee schedule, which is exactly what he said. It's an enormous technical challenge. It was motivated by the desire to make fees reflect the resources used to deliver care, as well as the relative value of those services. But to get that right for thousands and thousands of services while technology is evolving every minute, every day, is clearly an impossible task. And the political challenges that the RBRVS has faced over these years have been enormous. And so the notion of doing more of that at the federal level is not terribly appealing, although I think he's absolutely right when he says if we really want cost control, that means regulation. Now maybe that's something on the order of global budgets rather than rate regulation, but it's in the same general neighborhood. I don't see that as what we're going to tackle in the next year.
Most of what we're talking about in terms of cost control right now in 2009 is what I like to call faith-based cost control, things that have not been proven to control costs, like electronic medical records, like disease management, like prevention, all things that are worthwhile. None of them is going to control costs very much, I think, in the short run.